guys, we are back with another episode of our 25 Days to Question Your Induction series with Improving Birth Abbotsford. I'm Carly. I've been doing these videos since December because that's about the time of year that a lot of inductions get pushed on moms. And we're going to be reading from Why Induction Matters by Rachel Reed. She does the blog Midwife Thinking, and she's amazing, guys. I encourage you guys to check it out. I've got a YouTube video series now, the video channel with all of the videos that we've done so far. If you just want to check the playlist, I've posted it onto our Facebook page now for Improving Birth Abbotsford, and now you can also refer to your friends to the YouTube channel. If you're on a forum and you happen to see that somebody's saying something and you know that there's information in one of the videos, you can now link the video and put it into the forum, so then everybody can watch it. You don't have to worry about trying to find the Facebook post anymore. So that's one good thing. I'm going to be doing some stats soon as well. We have the 2016-17 stats. We have the perinatal reports. We don't have the hospital stuff yet, but there's a backlog of a whole bunch of stats from 2008 to 2009 and so on, and I'm going to be doing a basic little report thing, and you can refer to what our progression is. Basically, in BC, I've noticed that we don't have a big change in our maternal population in terms of age, health of mothers, weight of mothers. We don't have as big a change as people keep saying for why our rates keep going up every year. Our rates of C-section and induction keep climbing. They're not getting any better. And a lot of that has to do with profit, convenience, and liability, and the lack of informed consent for the part of the mothers. We are in a culture where it's basically, oh, well, you know, if you go past your due date, you have to induce. And that's not true. And the purpose of these videos is to get the information out there, because we know that a lot of people are not getting the facts that they need to make decisions. So the first video in our series is on the stats, and it's for BC, Fraser Health, and Abbotsford. So if you're not from those areas, you can skip that video and go straight to the next videos, which are the most important ones, I'd say, is the informed consent videos. Informed consent has what your rights are, what your care provider's role is in your care for giving you information to make decisions, how to make decisions, what questions you might want to ask. It gives you the framework, so then you can pose, well, what's important to me? What questions do I need to ask my care provider to make a decision for myself? And that can be encompassed for any type of medical care. It's not just for pregnancy. It will help you when you're making decisions for your children. It will help you when you're making decisions for yourself. I recently just had done, about a year and a half ago, I was told that I had a small tiny cavity in one of my wisdom teeth. And of course the dentist wanted to just yank them all out. I have 2 on the top and 1 on the bottom. And I used my brain, benefits, risks, alternatives, intuition, now or nothing, to basically make the decision, because I knew that my insurance was not going to cover the whole cost, and it ended up that they were going to charge me $1,400 even after my insurance covered most of it to have this surgery. And I weighed the risks and benefits and said, well, what happens if the tooth just gets filled? And they said, well, it probably won't work because it's still under the gum. Well, I checked in the mirror the other day and my tooth is broken through. And it was a good idea that I just got the filling done instead of having my tooth yanked, because there's nothing wrong with it now. So that's one of the things you really want to be able to make an informed decision about, whether the risks to you are worth the treatment or whether there's an alternative treatment. And that's why the informed consent videos are so important, and why we need to know our rules for informed consent and refusal. And the end refusal part is the most important part. So then we have our complications series. So if you have any complications such as pre-existing diabetes, gestational diabetes, hypertension, preeclampsia, cholestasis, uterine growth restriction, or small for gestational age, there's a difference. Or if there's reduced fetal movement, preterm, pre-labor rupture of membranes, and stillbirth, those are all things that induction was basically designed for. That was the complications that people decided we need to have a way of inducing a pregnancy that's not working. Then we have variations. Variations of pregnancy, it's just different from what the textbook says a pregnancy should go to, or there's something that is different about the pregnancy than what's normal. And I say normal in the sense that it's not, that we've skewed our normal rate. We've skewed our average with all these inductions that may not have been needed to be done. We've skewed our rates with our C-section rates. We've just skewed everything with the over-medicalization of our population for pregnancy. We don't even know what the gestational average is now. There's different numbers that get thrown around. There's like 41 and 3 is the average, 41 and 2 is the average, but it again depends on whereabouts in the population you are and what the practices are in that population, because I've seen home birth populations where women are having babies at 44 weeks. I've seen populations of women that have even had twins at 43 weeks and had no problems, or triplets, but that's not common in our medical area. So the medical system is skewing the average. So you really need to be able to look back to your family. So variations we've covered so far is postdates pregnancy, advanced maternal age, and vaginal birth after cesarean. And now we're going to go into the suspected big baby, because that's one of the big ones that a lot of women are inducing for. They'll say, oh, well, you know, I don't want my baby to get too big because then I'll have problems. Well, here's the actual information about that, and you can look it up yourself. I also posted the screenshots not too long ago, and it is on our page, but you'd probably have to scroll through. Eventually, I'm going to be putting all this stuff on a website, and you'll be able to see it from there. But for now, this is what we have. I just wanted to let you guys know that our rate of actual fetal macrosomia for Perinatal Services BC is less than 15%. I don't have the exact number with me right now, but you can go to Perinatal Services BC and you can check out under surveillance and then reports, and then check the most recent report. You can also check the backlog all the way to 2008 if you like, because that's when they started, was in 2008. They don't have the residence reports, and they don't have the midwife reports, but they do have the reports for just the deliveries. And then I'm going to be doing the long list of basically reporting year what the indications are. So that'll be something fun that we can refer to. If you're interested in what our maternal population is, it's actually a really fascinating report to just go through and look at the numbers. And again, I'm also doing the comparison report with that's very, very wordy, and you can refer to those too. I'm going to be doing it by indicator, not just as like one whole big long report, because it will take forever if I do it that way. So I'm just doing it by each indicator as I finish them, and each section, like each health authority. So I mostly focus on Fraser Health because that's where we are, and we also have the largest population in all of BC. But I also like to look at the other health authorities because it's comparable when you look at the other populations, and then you're like, okay, but why is it like this here? And it goes back to the way that maternity care is practiced. So for big baby, as I said, you can look it up yourself as well, and I encourage you to get this book. It should be available on Amazon soon. You can also get it probably from Midwife Thinking. There's a link, and then you can order it overseas, but you'll probably have to pay lots in shipping, and that's not always fun. So what does it say about suspected big baby? So a baby weighing 8 to 13 8 pounds 13 ounces or 4 kilograms or more is considered to be big, which is macrosomic. So the term large for gestational age is used to describe a baby who is on the 90th percentile at birth, meaning the baby is bigger than 90% of other babies at that gestation. Now, do you see a problem with that? That they are using percentile? We have a very diverse population. We have a diverse culture, and they're taking all the babies from all the cultural backgrounds and all the socioeconomic backgrounds, and then they're comparing one baby against all the other babies. So you could have a big baby, and it's normal for your socioeconomic background and it's normal for your ethnic background to have a big baby. Or you could have a very small baby, but it's normal for your ethnic background and it's normal for your socioeconomic background. But because you're comparing against all these other big babies, they'll say your baby's too small. Or if you've got a bigger baby and you have a family history of bigger babies and you're comparing against all these tiny little babies, again, that's skewing everything. So trying to do a percentile, I don't really agree with that. Just because we have a very diverse population, it doesn't take into account different ways that, like, we're all different people. I mean, if you go out in the world, we're not all the same size. So it doesn't make sense to do it that way. I think it's better to just go on a growth curve than to go on a percentile. And so the only way of determining the weight of a baby is by weighing them after birth, not before birth. Estimating the size of a baby by palpating and measuring the woman's pregnant bump is incorrect more than 50% of the time. So when they're feeling and they're measuring your belly, they may not be getting an accurate measurement because of the way your own body is designed, like how you carry your babies. I mean, I carry mine mostly to the back, which is awful, but I have a very small little bump. And then when they drop, I'd measure smaller. That's what happened with my son, and that's why I didn't even bother to worry when my daughter did the same thing. And I had a different midwife, and she was already aware of the problem. So I'm like, okay, I'm not going for an ultrasound. I'm not going through that again. But so baby's position and your individual anatomy can really affect the way that baby's going to measure. So the best available method of assessing a baby's weight before birth involves measuring their abdomen with the ultrasound. However, this method only predicts the weight of the baby within 15% of their actual weight. For example, if a baby's weight was 8 pounds and the ultrasound estimation could be anywhere from 6 pounds 13 ounces to 9 pounds 3 ounces. So the inaccuracy of weight estimation results in many women being incorrectly told that they are pregnant with a big baby. And a study in the United States found that 2 out of 3 pregnant women were told their baby was too big, according to ultrasound. Now in the States, their thing is that they just schedule a C-section. Here, it's more likely that you're going to be scheduled for an induction. But it's the same basic idea, is that you're still having an intervention for a suspected big baby. And the Society of Obstetricians and Gynecologists of Canada actually says in their guidelines for induction that suspected big baby is not an indication for induction. There needs to be other reasons besides that. And yet it still happens. So a lot of care providers that do that, they may be fudging the details a little, or they may just outright be saying, oh, well, it's a big baby and they might have gestational diabetes. It says it's fine, but yeah. You might want to look at your medical records if you were induced for a big baby. You can get them, you just request them from the hospital. They may give you the runaround, but you are legally allowed to have your medical records. They're yours. So get them. If you need somebody to interpret them, you can always see if there's somebody in the medical field who would be able to do that. A lawyer who's also, if you've had a pregnancy that went wrong, like badly, and you suspect that there was maybe there was a decision that was made that wasn't right, you can get your medical records and have a lawyer who checks for medical malpractice or just negligence and look them over for you. You can also just educate yourself on what everything really means. I mean, it's easy. You just Google it. You Google the terms and you understand it that way. I have a background in critical thinking and in research skills. So I just basically use my research skills to get the information. And I've learned quite a lot, that I can have a really good conversation with a midwife and we know exactly what we're talking about, and we're using the medical jargon for pregnancy, and I know exactly what she's saying. And I didn't know any of this until after I became a mom. So it's never too late to learn, and I encourage you to continue to educate yourself right up until the moment you're off this earth, because knowledge is power. So now they say here that in this study of the average with babies being basically induced or C-section for being big, the average weight was estimated of the babies estimated to be big was 7 pounds 13 ounces, which is exactly how much my babies weigh. The size of a baby is influenced by a number of factors, including genetics. Big babies tend to run in families, and many women will naturally grow a healthy big baby. In addition, babies who continue to grow throughout pregnancy, so they'll continue to grow. A baby at 42 weeks may be bigger than they would be otherwise at 40 weeks, but that doesn't necessarily mean they're going to be big. Because I have two friends, Wendy and Christine, who had babies at 42 weeks, and they were smaller than mine. So when you look at that, they could have had, if they'd been induced at 40 weeks instead of 42 weeks, their babies may have been only 4 pounds, which is a very small baby. But instead they have like 6 pound and 5 pound and a few ounces babies. So again, your own gestation may be naturally growing your baby to the right size that they need to be to come out. Now, there's only a difference with abnormal blood glucose levels. So uncontrolled gestational diabetes or pre-existing diabetes, basically. But in that case, it's not fat that's being added on. The difference is that their shoulders and chest are larger and fatter and are more likely to encounter the complications. So if you don't have pre-existing diabetes and you don't have gestational diabetes and you have relatively normal blood glucose levels, then there is no reason to believe that that baby is going to get stuck unless you're flat on your back and not able to move into the positions that you need to be. So unfortunately, the research into big babies often combines the outcomes of diabetic and non-diabetic women. So that's problematic because it can be difficult to assess a big baby who is the result of a healthy pregnancy and the outcome versus the outcome of a woman's baby she had gestational diabetes and the baby was too big in the shoulders and chest. So when they say, oh, well, baby's going to get stuck, they're combining all that research and they're taking two different populations, two different demographics, and trying to mash it together and make sense of it. They need to be taking women that have big babies that don't have any complications. But because we have those women being induced, just like the ones that have gestational diabetes, we don't have those numbers. So by doing that, there's also a problem here. Babies who are in the 91st to 97th percentile, they have a lower risk of stillbirth. So you want your baby to be bigger. You don't want to induce too soon, because maybe when babies get that fat on them, that helps them when they're in the outside. So it's 0.1% in comparison to smaller babies, and the percentage varies according to gestation, obviously. However, very large babies in the 98th percentile have an increased chance of stillbirth at 2%. But again, they're combining healthy moms and moms with conditions that are leading to the big baby and may also have the complications. So, because it also says this may be because babies in the 98th percentile are more likely to have a diabetic mother and or have congenital abnormalities. So birthing a big baby is associated with complications such as severe perineal tearing, and that number is 0.6%. Not 6%, 0.6. So 6 women out of 1,000 will have severe perineal tearing with a big baby. We don't even know if that's because of the position they're in, if they have directed pushing, if they have other interventions such as an episiotomy. I mean, if you cut fabric and then tear it, it's going to tear a lot faster and harder than if you're just trying to take some fabric and pull. It's not going to rip. So that's part of where you have to look at, okay, well, how many of these were managed births in which interventions were used? We don't have that information, but it's one of those questions you might want to ask. There's postpartum hemorrhage of 1.7%. And again, you have to wonder if that's because they are rushing baby out as opposed to letting baby come. Are they tearing at are they pulling the placenta out too fast? What are they doing in these cases? What's contributing to this? What are the home birth rates compared to the hospital birth rates? We don't know. Big babies are also more likely to have low blood glucose at birth of 1.2%. However, again, that was mentioned in the gestational diabetes video, that is one of the possibilities of babies with gestational diabetes. They come out with the low blood glucose levels. So that could have been a result of combining all those women. Temporary rapid breathing of 1.5% and a high temperature of 0.6%. So again, though, you have to remember that they're combining healthy women with complications in these studies. So the main concern care providers have about big babies is the risk of shoulder dystocia. That's what they'll say. A lot of them will say the shoulder dystocia. And shoulder dystocia occurs when the baby's shoulders become stuck in the pelvis after the head is born, resulting in the delay of the birth of the body. Now, in a physiological birth, and in home births, they usually just move the mother and have her maneuver into different positions, and baby will wiggle free. In the hospital, they're more likely to pull at baby and cause problems because that's the way that they were taught. A lot of medicine, they do things the way they do them because that's the way they were taught. And until evidence comes to the contrary to say, hey, you shouldn't do this, they keep doing it. Sorry, I had to clear my throat. So then it says that care providers may need to assist the woman in positions to release the baby's shoulders, and in some cases they may need to move the baby's shoulders with their fingers. And this can be a traumatic experience for mother and baby, and in some cases results in birth injuries. The incidence of shoulder dystocia increases with the size of the baby. For example, it occurs in around 1% of babies weighing less than 8 pounds 8 ounces, compared to 5 to 9% of babies weighing 8 pounds 8 ounces and 9 pounds 9 ounces. So again, you have to also wonder what positions that they're in and how the labor is actually progressing and what interventions have been put in place, and what's the difference between a physiological birth with a big baby versus one that's heavily medically managed. The other thing is the complications associated with big babies may be due to the interventions carried out when a baby is suspected to be big. So just suspecting a big baby can lead to more interventions. In one study, compared the outcomes of the group of women who were suspected to have a big baby, compared with a group of women who unexpectedly gave birth to a big baby. Women who were suspected of having a big baby were 3 times more likely to have an induction or a cesarean. So just suspecting a big baby led to these interventions. And they were 4 times more likely to have complications such as severe perineal tearing and postpartum hemorrhage. So again, just suspecting having a big baby led to these things. In this study, there were no differences in the incidence of shoulder dystocia. between the two groups. Another study found that care providers were more likely to diagnose slow progress during labor and recommend a cesarean if they suspected the baby was big. Women who are told that they have a big baby are counseled about potential complications, and they're significantly more likely to choose a planned cesarean or an induction in our case. And therefore, when a baby is suspected of being big, a woman has an increased chance of interventions during birth and of experiencing complications caused by those interventions, even if the baby is not actually big. The perception of a baby's size influences the outcomes more than the actual size of the baby. So it's mind over matter, basically. If you think you're going to have a big baby and you're going to have problems, that may actually lead to you having problems. Then if you say, I'm birthing the perfectly normal size baby for my body, and my body is not going to give me a baby that I cannot birth. A lot of the time, just the fear that you're not going to be able to birth can lead to your labor stalling. We will be getting into that in the spontaneous labor chapter, and I'll explain how mind can actually influence how your labor progresses, because it's actually really fascinating. So some care providers offer an early induction for a suspected big baby to reduce the chance of shoulder dystocia. We know this to be true. So a Cochrane review comparing induction of labor before 40 weeks for a suspected big baby with waiting for spontaneous labor found that induction decreased the incidence of shoulder dystocia from 6.8% to 4.1%. However, they also found an increased rate of perineal tearing in the induction group of 2.6 compared to 0.7 in the spontaneous labor group. And an increase in the treatment for jaundice for the baby, 11% compared to 7%. So the World Health Organization and NICE, they basically both state that induction of labor should not be carried out simply because the baby is suspected to be big, which is the same as the SOGC, the Society of Obstetricians and Gynecologists of Canada. Women can and do give birth to big babies without any problems. The physiology of birth involves the mother and the baby working together to move the baby through the pelvis safely. The baby's skull molds to fit the shape of the mother's pelvis and can increase in size considerably if she's mobile. So if you're in a bed, if you're stuck in a bed with an IV and an epidural, you're going to likely not be able to move around as much, so you can't get your pelvis moving. So the woman's pelvis can increase in size considerably if she's mobile, and avoids restricting the back of her pelvis by sitting or lying on it. That's why I always say stay off your back. I was on my birth ball a lot. I was leaning forward a lot, and I was moving my hips a lot, and I was doing deep squats, and that opened up my pelvis a lot for my babies with their big heads, and they didn't have big shoulders, but they had big heads, and I was able to birth them just very easily. And I birthed my daughter so much easier than I did my son, same size baby, just because of the different environment that I was in. We'll get into that when we get into our spontaneous labor video, but that's just really interesting. You really should be learning about physiological birth and how your pelvis actually works and how your body works, because if you know those things, it is much easier to feel confident that you can do this than if you don't know how your body works and you just listen to what the doctor tells you of how your body works, because sometimes they don't even know. Doctors have very rarely witnessed a physiological birth, and the ones that have are usually family physicians, not obstetricians. So if you see in the hospital rates, you'll see the more that there's a trend towards obstetricians in the hospital, the higher the induction and C-section rates than if you have a large population of women that are choosing family doctors over obstetricians. The rate may be high, but not high as it would be otherwise if it was just obstetricians. It's just the way that they're differently trained and what they've seen. So It says the woman's perineum is capable of stretching without tearing if she follows her instinctive urge to push. So no directed pushing, guys. And changes position in response to her body. Once the baby's head is born, there's a pause as he or she wriggles and rotates their shoulders to move through the pelvis. So baby could basically birth themselves, and they do. A lot of home births, and even my daughter, like they come out on their own, and you don't really have to do anything other than just let it happen. So they're ready to be born with the next contraction. Interventions that interfere with the physiology and instinctive birth, such as an epidural, a reclining birth position, directed pushing, and pulling on the baby's head, can increase the risk of complications for any baby, especially a big baby. So that is all really important stuff to understand, because we have a very highly medicalized system. And that's why I say that you might want to hire a midwife or find a care provider like a family physician or a more natural-minded obstetrician. They are out there. But you need to know what questions to ask, like how do you support a vaginal physiological birth? And you don't just want to say vaginal birth, because vaginal birth can mean a lot of things to different people. When people say, oh, I had a natural birth, they may just be talking about an unmedicated birth. And an unmedicated birth is not the same thing as a physiological birth, because you can still have interventions within that physiological birth. If you say, oh, I had a vaginal birth, well, you could still be medicated, and you could also have been induced. You could have an augmented labor where they break your water. You could be in an awkward position. You could have directed pushing. You could have them pulling on the baby. It's still a vaginal birth. Vaginal birth with episiotomy is still a vaginal birth. That's why I distinctly say physiological birth, because physiological birth is undisturbed birth. Vaginal birth can be anything. It's just the absence of a cesarean. It's not a surgical birth. But a lot of people will say, oh, well, yeah, we do vaginal birth here. But they're talking about vaginal birth with an epidural. And they're more likely to suggest the epidural than they are to suggest alternative positioning, or hey, maybe we can try this counter pressure method. Maybe the reason why you're in so much pain right now is because baby's head is turned the wrong way, so we can try to get you into a different position. That's why I also recommend having a doula, because doulas are familiar with spinning babies. They're familiar with different techniques to get a baby to get into a more favorable position. They're just a great asset to have. And they can train your partner too, your birth partner. If you have a birth partner, support person, your doula will also teach them so that they can help you. And even if you're going through a prodromal labor, say, and your doula is not going to be with you the whole time because it's going to be over a course of days, they can tell your partner what to do for comfort measures. My doula was absolutely invaluable to me both times. She missed the birth both times because that's just the way my kids roll. I guess they wanted mommy all to themselves. I don't know. They still kind of want mommy all to themselves. So it could very well be that. But the fact is, she missed the birth, but she was still very helpful in my labors. And she gave me a lot of information and a lot of encouragement. So doulas are fantastic, guys. They are a fantastic thing. And if you can't afford the lump sum, some will do a sliding scale. Some will say, okay, well, you only need to cover my expenses for childcare if they have other children, or for travel expenses. They are willing to work with you because they understand that the system is not set up for physiological birth, and they want to help. They want to help women. It's not just about the money for them. They didn't get into it for the money. They got into it to help women. So if you think that a doula would be helpful, get one. Get one. I didn't think my doula would be helpful because I was planning a home birth with my son. And my midwife said, well, actually, for a home birth, I would suggest you get a doula. And if you're even having a hospital birth, I suggest you get a doula. And she worked with me to find my doula. And she's just amazing. And that you can ask a midwife, well, do you know any doulas? And you know what? We know doulas. We know doulas here in Abbotsford and in the Fraser Valley. I talk to them all the time. So if you are in the Fraser Valley and in BC particularly, I know some doulas in BC that can help you. And if they're not in this province, I can also try to find resources for you to find doulas in your own province. So contact us for if you're like, hey, I'm trying to find a doula, or hey, I'm trying to find a midwife, or hey, I just need more information on this. Can you give me some information that you've dug up? I do it all the time. I dig it up just for the fun. So again, share these videos. Definitely share this one, especially if you're seeing on the forums moms saying, oh, well, I'm trying to avoid an induction, but if I don't go into labor by this date, I'm going to have to be induced because my baby's suspected to be big. You can share this video with them and share the informed consent videos. Those two are going to be so invaluable. Even if she still chooses induction at the end, the fact is she has the information and she's made the decision for herself after having all the information, and she's weighed the risks and benefits to herself. We can't tell people what to do, and we don't want to tell people what to do. We want you to just have the information so that you know, okay, here's the risks. I'm okay with these risks because I'm not okay with these risks. Or this doesn't fit my situation, or I'm not wanting to change my mind. And that's totally fine. But legally, you have the right to this information. And the last thing I want is for a mom to go and make a decision for herself without having all the information, only to come back later and be like, I wish I'd known this because I wouldn't have induced if I'd known this information. That's what we want to avoid, is we want to avoid women going and making a decision and then coming back and feeling bad about their decision because they didn't have any information, and then being like, well, why didn't anybody tell me? Well, I'm telling you, it is always your choice. This is what it says about Big Baby. If you still don't want to risk it and you want to induce, that's perfectly fine. But you need to have this information so that you can then reduce the risks to yourself and be like, okay, what can I do to make this a positive experience? And we will be doing a video on how to have a positive induction, because sometimes induction is needed. It's needed for the complications, and sometimes a variation you may want to induce. But that's all the time we have now. So I will see you next time. Bye, guys.